Hello there. Today's case starts with this ultrasound image on a 23-year-old female patient. On this limited image of the right kidney, you see part of the right kidney here and then this well-defined lesion. The lesion is anechoic, meaning that it's dark and has a posterior enhancement consistent with the cystic component. But the lesion also has this component that's extremely hyperechoic, meaning that it's very dense. To simplify things, this is suspicious for chunky calcifications within the posterior wall of the abnormality. This calcium here makes the cyst a complex cyst rather than a simple cyst. The radiologist who saw the ultrasound recommended a CT to make sure this is not a neoplastic process, and this is the CT. I'll give you a chance to look at this lesion in different phases. So this is the pre-contrast phase. This is with contrast in the arterial phase, and notice how the cortex of the kidney is enhancing. And this is a portovenous phase where you have enhancement of the veins in addition to the aorta. And here's the lesion again. The idea behind doing the CT scan is that there is always a concern if you have a complex cyst that this cyst might turn out to be a renal cell carcinoma. A small percentage of renal cell carcinomas may appear as predominantly cystic lesions. And in such cases, you'd have to look for features that suggest malignancy. Those features would include abnormal high density of the cyst, soft tissue component, enhancing components, thick or nodular walls, thick or nodular septations, and chunky calcium. Some of these features are more worrisome than others. For example, an enhancing soft tissue component makes this an RCC till proven otherwise. While other features may be either ignored, followed, or excised, depending on how they look. So calcium, depending on its appearance within a cyst, may be ignored, followed, or surgically removed. Here's the dense calcific component that was suspected on ultrasound. This is the cystic lesion seen within the kidney. And the cyst has no other concerning features. The wall is imperceptible. There are no nodules, soft tissue components, or enhancement. So the only concerning thing here is the chunky calcium. If the calcium is smooth, small, punctate along a septum, this could be ignored. If the calcium is associated with the nodular, soft tissue components, enhancing components, or other concerning features, it should be excised. Sometimes calcium is in between. It's indeterminate because it's thick, chunky, nodular. So this you could follow. So looking at this type of calcium, everything else is okay, and it makes sense to follow this lesion since the calcium here is in the indeterminate group. The patient presented 4 months later with abdominal pain, so a CT was performed to rule out renal stones. This kind of CT is performed without contrast to see calcified stones, and it's called kidney ureter bladder CT, KUB-CT. The patient did not have calcified stones, but here we see these calcific components within the cyst again. And we see this chunky and thick area of calcifications within the cyst again. But did you notice something unusual? One way to do the KUB-CT is to put the patient in the reverse direction, meaning that instead of placing the patient in a supine position within the scanner, the patient is placed in a prone position. And the reason some hospitals do this with KUB-CT is to make sure that a stone within the urinary bladder is mobile instead of stuck within the ureterovesical junction. This is the table, and notice how the patient's abdomen anteriorly is facing the table where the back is against the table. And the unusual thing here is that the calcification that we saw is facing anteriorly. On the previous CT that we saw that was performed with the intravenous contrast, the patient was supine in the opposite direction. And the calcium in that case was away from the liver. It was more posteriorly, while here it's anterior. So most of the calcium moved to go to the dependent location with gravity. Let's go back to the previous CT scan where the patient was lying supine. He's facing anteriorly where the back is against the table here. And here we see the calcification being away from the liver. So the calcium is going all the way down with gravity to the dependent location. And this changes everything. Instead of the calcium being fixed and chunky, this is something else. When you have calcium within a cyst that's sludge-like and mobile, this is what we call milk of calcium, which is very good news for the patient because milk of calcium is not a concerning feature, it's actually an ignorable finding. Remember the ultrasound image that I showed you initially? The patient was scanned there while he was supine. All of the hassle and anxiety associated with this cyst would have been avoided if the person scanning the patient would have done one thing. And that's to move the patient, scan him on her side or in a prone position. By doing that, the radiologist would have noticed the mobility of the calcium within the cyst, and this would have been diagnosed as milk of calcium, which in turn would make this a cyst that's ignorable from the start. So let's summarize what we learned from this case. First, some renal cell carcinomas may be cystic. And that's why when kidney cysts are seen, you want to define them as being simple or complex. Some complex features make the cyst a surgical cyst to be excised. However, others could be followed or ignored. Concerning features would be thick nodular walls, thick nodular septations, soft tissue enhancing components, or even high attenuation of a cyst. Calcifications within a cyst is a feature that makes a cyst complex. If calcium is thin, smooth, and punctate, this you could ignore. Also remember, you could ignore milk of calcium, and that's the most important teaching point today. If you move the patient, that's an easy diagnosis. So in doing an ultrasound on such a patient, always move the patient to his side or to the prone position to make sure the calcium is not mobile. If calcium is associated with other concerning features such as an enhancing soft tissue component, this has to be excised. If calcium is chunky, thick, or nodular, that you could follow up. And by that, we end this case. Thanks for watching and see you with more cases later. Hi there, this is a quick show and tell chest x-ray for juniors. This is a female who's 81 and complains of shortness of breath. The initial impression is that of cardiac enlargement. Although that's likely true here, there are other findings. You may think that the entire opacity here represents the cardiac shadow. However, the heart is only confined to this opacity here. And this part here has a different, more heterogeneous appearance, which appears relatively lucent to the real cardiac shadow. Not only that, if you look carefully, you'll notice that you have a straight line here and there. This represents a fluid level. Although this looks like an enlarged heart, the rest of the opacity actually represents a hiatus hernia containing bowel loops. And the presence of air and fluid within the hernia indicates that you have bowel loops within the hernial sac. This is the lateral chest x-ray, and as we always emphasize, the lateral x-ray is usually very useful. Here's the enlarged heart, which is displaced anteriorly, and this is the hernial sac containing bowel loops with fluid levels. So the diagnosis here was a large valve-containing hiatus hernia displacing the heart anteriorly. We learned from this quick case that not every cardiac enlargement on chest X-ray is really related to the heart. You need to look more carefully. When you see cardiac enlargement, make sure you don't see double borders or heterogeneous or fainter opacities than the heart to decide if this is really heart or something else. And always be careful when you see straight lines. A straight line denotes a fluid level. Finally, don't forget to look at lateral chest radiographs to confirm any abnormality that you see on a frontal radiograph. By that, we end this case. Thanks for watching and see you with more cases later.